are thinking to check the urine output or weigh. All right, so we're not going to get an ABG because we're concerned that this very small little baby might end up in fluid overload very easily. With ultrasonic nebulizer, that's providing humidity or it's providing aerosol, but it's providing a lot of aerosol. And that's the whole point of using ultrasonic compared to just the regular aerosol therapy. You can control your output, and your output is usually, again, like double or triple the amount of just a normal nebulizer system, aerosol system. And this is usually, of course, for oxygenation. So this is a case of they order hydration therapy for this one, and you figure that I can adjust my output with this ultrasonic. But you gotta be careful because weighing only this many grams, then this baby is extremely high risk for lots of problems. And there's no need to really monitor the output because you are controlling it with this device. And that's not necessarily going to tell you whether or not the baby is now possibly in fluid overload. Really, the standard of practice is always to weigh the babies. I mean, the babies are going to be weighed frequently. If not daily, then they're definitely going to be weighed as needed, especially when you're concerned as far as maybe too much fluid or maybe not enough fluid. And that's how we kind of keep track of what's going on, by just literally weighing them. Everything gets weighed in the nursery, just about, even the diapers. Like when they're trying to do their figures for the INOs, like the fluid balance status, intake output, if the babies are, of course, at risk of dehydration, they have to kind of approximate how much urine that they're putting out by literally weighing the diapers. And then that way you kind of get a rough idea of what's going on with fluid status. Now, here's how it turned out, where the majority still felt like the urine output would be a good way. But again, there's really not an easy way, besides, again, like the weighing the diapers kind of thing. And then also keeping track of IV fluids, like how much is going in. Okay. Now, so we start off with the mom. I mean, mom, she could have diabetes before she gets pregnant, and that would be considered chronic diabetes. And this is also pretty much is known as pre-gestational diabetes. And if she does have it, then that, of course, really can potentially complicate things for not just her, but also for the unborn baby. So for her, this could send her into diabetic ketoacidosis when she's carrying the baby, or she can end up with that really unexplained, like, high blood pressure. She's dumping a lot of protein in her urine, and then that could transition into eclampsia, which is basically she could end up with seizures. She could end up like convulsions, seizures, that kind of thing. And then for the baby, it could lead to a lot of possible complications as well. So this is just one of those things where if you have, especially if it's uncontrollable diabetes, before you get pregnant, you have to try to get it under control, because it's going to place both you and the baby at a major risk. And at least, again, just be on some plan for treatment. So that way that kind of limits the potential problems. So this again, just kind of think about as you're going through the chart, because if you're on that delivery team, you've got to identify as many risk factors as possible as you're doing your chart review. And then gestational diabetes, this happens sometimes a lot, and other times it may not happen that often, but this could lead to some long-term problems for mom for sure. So she, let's say, had not ever had any problems with diabetes before. And as once she got pregnant, then that transitioned into this gestational diabetes. And then after she delivers, she may end up having diabetes for the rest of her life. So she may end up in a type 2 type of situation. Now, for the baby, these babies are usually born pretty large. And the term that we use here is macrosomia. A normal size baby should be right here. Let me write over here. Normal weight is about 6 pounds, 6 to 7 pounds. And this is the equivalent of about 3,000 to about 3,500 grams. Now, the textbook says that macrosomia is greater than 4,000 grams. But really, if you look at this baby, he looks to be a little bit bigger than 4,000 grams. So that just means that macrosomia could be, by textbook, greater than 4,000 grams, or it could be like the I don't remember what the Guinness record is for the heaviest baby, but I think the last time I saw it, it was someone, I think in the UK, who delivered a baby who was over 13 pounds. So then you ask yourself, how does this happen? It could have been this. It could have been that mom developed gestational diabetes. Or the other thing that leads to these really, really large babies, large for gestational age babies, would be if they were not delivered beyond like 40 weeks. So let's say they've been in utero for a long time when they should have been delivered, say like at 38 weeks, 39 weeks, 40 weeks. Maybe this was a baby who wasn't born until like 44 weeks. Then you have to ask yourself, well, how does that happen? And that's going to be usually on the mom. She's again maybe not following up like she's supposed to with her OB. And if she was, they're not going to allow you to continue to carry the baby for that long, because that's going to be a concern, because the longer the baby's in utero and it's that late in pregnancy, they are already stressed out. The baby's stressed out. There's no room left to move, and they're just ready to get out. And that leads to a lot of the meconium. They start doing a lot of pooping, and then that poop ends up in their airways, unfortunately, and in a lot of cases. So again, any OB who is going to be concerned is going to just, of course, induce labor well before you get to that stage. But then back to this macrosomia case right here. Well, just to give a quick and dirty of what's going on, well, why these babies get so large, is you think about the two sides of what's going on. Mom eats, and let's see, mom, we'll start with, I'm just going to kind of go like stepwise. Step one, mom eats, and then the second thing that happens is blood sugar increases. Now, if blood sugar increases, then the pancreas is supposed to those little beta cells in the pancreas was going to secrete the insulin. So then the thing about this is she may become desensitized to the glucose in the blood. And that'll be for a reason. The reason why she becomes a little bit more desensitized is that the end goal is to feed the baby. The baby needs that sugar. So we'll just still keep it as that she's going to secrete the insulin. And then if she secretes the insulin, then that's going to make sure that her cells are going to pull in the insulin or pull in the glucose. So for insulin causes her cells to pull in, I'll just say pull in the glucose. And then now, 5, the remaining glucose is passed on to the baby. And I go back and forth between using the correct terms and just using the generic terms. Of course, when I say baby, we know we're talking about a developing fetus. So passed on to the baby, I'll just write fetus here. So this is what would normally happen. And the placenta is secreting all these different hormones. I mean, mostly like growth hormones that is causing her body to become more desensitized to the glucose, meaning that her blood sugars could go up pretty high. But because of the hormones that are being secreted by the placenta, there's not going to be that much of a response anymore, meaning that there's not going to be that much insulin being secreted to bring that level down. And again, that's by design. That's so that all that extra sugar now is just going to make its way to the baby. But what if she is completely insensitive to the glucose? And that's a problem. So if she becomes completely insensitive to it, that means that her blood sugar levels are going to be really, really high. And then all of that extra sugar is now going to make its way into the baby. And now the baby's pancreas is going to be forced to have to secrete a lot of insulin because that's going to be just way too much. And then as the baby's pancreas is secreting this insulin, then now the baby's cells are pulling in all this extra sugar. And now the baby's getting bigger and bigger. He's gaining more weight. He's gaining more weight. He's getting bigger and bigger and bigger until you end up like a 13-pound macrosomia baby. And then the problems don't stop there. So after this macrosomia baby is born, if it was due to gestational diabetes, now he is going to experience some major metabolic challenges. So not only is he at risk of developing diabetes, but he's also immediately going to have issues with his pancreas is still secreting a lot of insulin because he was so used to all of this extra sugar that was coming from mom. Now that he's not in utero anymore, his blood sugar levels are going to drop drastically because of all that extra insulin that he's producing, and his blood sugar levels are not going to be that high anymore. So it just creates a serious case of hypoglycemia for this little one. And then they've got to give him sugar. So that's gonna, you have to get on that like immediately. And of course, the obvious, if you're trying to deliver a baby this size naturally, then it could create a lot of trauma. And not just for mom, but also for the baby. And the baby will sometimes get to the point where they end up with like they dislocate something, like a shoulder could be possibly dislocated. The nerves, like the plexus, like that brachial plexus, and right around the shoulder, that will sometimes get damaged, and then the baby will end up having like permanent nerve damage and maybe have some drooping on that one arm, and it could be pretty bad. So in a lot of cases, if they recognize that this could be some of the things that are going to possibly happen, they'll just electively go ahead and schedule a C-section, and that'll help to at least minimize some of this type of trauma. And then not only could you end up with a baby that's like really, really large for gestational age, you could also end up with a baby who is born way too early. Now, you're also looking in the chart for this organism, and this is a common organism. I mean, mom is usually colonized, as they say, like almost half of the moms are going to have this GBS, which is just group B streptococcus. And if you're, again, planning on delivering normally or naturally, then the baby is going to possibly end up picking up this organism as he's being born. And then another thing about this GBS, what if her water breaks early, which is the PROM here, the premature rupture of membranes? So if her water breaks early, then because of this organism being all in the birth canal, it can migrate and easily make its way now into the uterus and cause an infection. And then other things like herpes. Now, this is not the way that we do this today. We don't call them STDs anymore. We call them STIs, which just stands for infection instead of saying a disease, because this is almost like a misnomer. It's not always going to result in a disease, but they're all going to cause an infection, whether it's herpes or gonorrhea or chlamydia. I mean, you name it, they're all STIs, and that's the convention that we use today. Herpes, as you know, does not go away. That virus will remain dormant until it reappears again, usually when you're compromised, like you're immunocompromised, or like in this case, you know, you've got a mom who is carrying a baby, and that's a lot of stress on the body. So then that will sometimes probably reactivate this virus, and then again, if the baby is now being delivered naturally, then that just places the baby at high risk as well. And then while we're talking about STIs, it used to be that I think today, because of better medication and treatment options, when you think about, like, say, a mom who's HIV positive, does that mean that the unborn baby is at risk? Not necessarily. Even if the baby was born naturally, then there's still not that much of a concern as far as passing the HIV over to the fetus, but there's still always the potential for that to happen. In fact, that's when the bloods are going to possibly have the best chance of mixing, is during the birth process. So here we are, HIV and hepatitis B. So again, it's not a guarantee that all the babies are going to end up infected if the mom is definitely positive for any of these, but it could still happen. So they're saying here about 30% of the cases will lead to this. So if you already see, like, if the OB already knows that the mom is, like, you know, she's got hepatitis, then chances are they're going to go ahead and start something. before it even gets to that point where it's close to delivery. This is going to be like very early on, usually, to help to make sure that you lessen the chances of the baby contracting something. And then again, the name of the game here is just recognizing risk factors as early as possible. By the time they get to the hospital for delivery, a lot of these things should have already been discovered, and then they'll be in the chart. And then we got other organisms that we're always concerned about. I mean, this is just not by any means a complete list, but these are going to be probably some of the more common things like the cytomegalovirus, for instance, or rubella. And then toxoplasma. This organism, as we know, if you're expecting, you're always going to be advised not to be near cats. And it's not that the cats themselves per se are going to cause potential harm to the unborn baby. It's this organism whose life cycle depends on cats, and it ends up in the cat's poop. So their litter boxes is what's of a concern for someone who's expecting. And then, of course, TB, and et cetera, et cetera. Again, like I said, when you think about STIs, it can be pretty much, like anything from like just basic syphilis or whatever the case may be that will be risky. And then fetotoxicity. Fetotoxicity. This is usually the mom who's just not following the best advice. So this goes back to, again, the school of thought. Sometimes, from what I hear, sometimes an OB would let an expecting mom know that one glass of wine every now and then is not going to be that much of a problem. And then you've got others who are going to be hardcore, don't even think about it. Just drink water, and don't even run the potential risk. Because as you see, alcohol is a very potent teratogenic agent, which means that it can create a lot of birth defects. And of course, the obvious, the smoking. With smoking, this is when you really do end up with those cases of really, really, really low birth weights. We're talking like ELBW, less than 1,000 grams, or IUGR. They just could not completely develop in utero like they were supposed to because of the smoking, and et cetera, et cetera. So this should go without saying that if you're doing something that's toxic, it's going to potentially cause some complications for the baby. All right, now the worst thing that you can imagine is that the mom was still abusing like some really hardcore drugs, like she was still doing cocaine, for instance, or whatever the case may be. Then the baby's going to end up hooked on this stuff as well. And then you've got to now go through this whole detox process with a newborn baby to try to get them get this stuff out of their system and get them on track. Okay. So here we are with the preeclampsia. Now, no one really knows. No one still knows. All these years of research and everything, they still don't know exactly what causes this to happen. Now, they have a lot of things in mind, and there's a lot of risk factors that they see that can be related to it, but at the end of the day, they really don't know. But preeclampsia is usually just that. It's just, you've got some hypertension. Now, ordinarily, your blood pressure is supposed to be lower than normal. But when you start to see it creeping up, then that could definitely mean that, and you've got maybe like some other signs that something's not right, like you may be a little bit dizzy, or a little bit, or not necessarily dizzy, but you're going to really feel that something's not right. And then they'll probably end up diagnosing you with preeclampsia. Now, the common things that they do see with this is, of course, not only the high blood pressure, but also the proteinuria. So they check the protein levels in the urine, and if they're excessively high, and there's a lot of swelling, like there's a lot of pedal edema and things of that nature, and it's around the second trimester. It's like starting around the second trimester, heading into the third trimester, then chances are they will just diagnose you with this preeclampsia. And they're going to treat you so that it hopefully doesn't advance into eclampsia. So these are the things that they see that are all kind of like probably precipitating factors. Multiparity just means that you've delivered a lot of babies, and that also age. It's sad, but we used to say that a woman over 40 is placing the child at risk of, something like maybe some kind of genetic anomaly like Downs or something of that nature. But then other places I've looked into, they say that advanced age would be like more than 30, which is like, wow, what's it going to be next? Over greater than 20 years old is advanced maternal age. But either way, we know it's just like it's like a generality. It's stating that older you are, the more likely that there's going to be some problems, because it's not guaranteed. And of course, if they already had hypertension to begin with, then, and CRD is chronic renal disease, diabetes mellitus, and again, they've been pregnant multiple times, and then even like the hydrops fetalis is something, and this will be the baby who ends up being born and they're essentially just like swollen. They're like extremely edematous. So now here we get into this whole like classification system, and because you're part of the delivery team, you would have to be familiar with this type of classification system, just like the nurse has to be. And depending on the OB, how they write their notes, they may use like just 2 digits, like the G and the P. They may use 3, like the G, the P, the A, or they may do 5, which is probably going to be a little bit more common in some cases, where they'll do a G, the T, the P, the A, and the L. And so it's kind of like code, like what does this mean? So we start off with some terms here. We're going to just start with the general, like the G would mean gravidity. So gravida, gravida, gravidity, it's the same thing. It's just saying that how many times have you been pregnant? And it doesn't matter if you're pregnant with, say, like you're expecting twins or you're expecting triplets or whatever. It's just going to count as a pregnancy, and that's it. If the mom is currently pregnant and she's been pregnant one time before, then her G number would end up being 2. So it always takes in consideration the current pregnancy, if she is, and then how many other times she's been pregnant. And then the para, or the parity, would be the number of births and viable offspring. And, I'm going to adjust this a little bit, because with parity, what if the baby was unfortunately born stillborn? That's still going to count as a parity. So not just viable, but viable and non-viable. Because this is where some people get it wrong. They think it's just if the baby was born alive. No, not necessarily. And we'll see that more clearly when we look at the 5 digits when they're all together, looking at the G, the T, the P, the A, and the L. So we're going to say viable and non-viable. And again, with the parity, what if it were twins that were delivered? Then that's still just one. Or if there were triplets, that's still just one delivery. No matter if it was 2 hours apart from each other, they was still considered to be one delivery. And then A, now A is not necessarily saying that she had a scheduled abortion. I mean, that could be part of it. I mean, that's like, that'll of course be an abortus, but abortus also means like you lost the baby. I mean, like, you know, you had like a spontaneous abortion, which means you miscarried. So that will really be kind of like the umbrella statement for you weren't able to you lost the baby for whatever reason. And again, if you have twins, you lost both twins, that's going to count as one for A. And now, premigravida this is the very first time. And again, this is all about high risk. If this is what's going on, she's at risk. This is her very first time of delivering. And also, this could be risky. Multigravida would mean that she's delivered she's been pregnant more than 2 times. And the more multigravida it is, of course, the more of a risk that there could be for the baby. And then grand multiparity is more than 5. And then one more that they didn't add, but we can add here is what about a mom, or not a mom, but what about a woman who's never delivered or never been pregnant before? Then they will call that nully. Because null means like void, like nothing. So nully gravida. And then these prefixes here, the primi or primi and multi and nully, they could also be used for the parity as well. They could describe it as like nully parity or primi parity or something of that nature. So either way, this is what it breaks down to. Now here, G5P3A1. So let's see if we can decipher what this is saying. The G5 would mean that either she's currently pregnant and she's been pregnant 4 times before, which would give us our 5, or it could mean that she is not currently pregnant, but she has been pregnant 5 times in the past. So that's what the G5 could mean there. And then the parity of 3, that just means that she has delivered 3 times. Now, could that mean that she delivered maybe some twins during one of those deliveries? Possibly. Or what if she delivered like triplets during one of those deliveries? Possibly. But just remember, your parity is not going to tell you how many babies. It's just going to tell you how many deliveries, and that's it. Same goes for the gravity or gravidita. Gravida, good gracious. Just like the gravida, it means that this is how many times she's been pregnant. It's not going to tell you how many individual babies that she was pregnant with. And then, of course, the abortus would mean that, in this example, A1 would mean that this is possibly like one child that she lost, or it could have been maybe twins that she lost, or triplets that she lost. So just these by itself is not really enough information to know what's really going on. This is kind of like just a ballpark figure of like just what's going on in her obstetric history. And then one more thing I wanted to write here, always use 20 weeks as the, what's the word I want to use here? 20 weeks as the indicator. And by this, what I would mean is that if we're looking at like para or parity, we're saying greater than 20 weeks. And the same would go for the abortus. We would say like greater than 20 weeks. But this will make more sense when we look at everything all together, like the GT-PAL. And in that way, we'll have definitely more information on what's going on in the history. So now with the G3P2A0, again, this could mean that she's currently pregnant, but she's been pregnant twice in the past. And the P2 is just saying that this is parity, so she's delivered twice. Again, we don't know how many, but she has had 2 deliveries in the past. And then abortus would mean that there was no no losses. Now, here's the rest of it. Here's the part that really breaks it down. But be aware that once you look at GTPAL, P does not mean parity anymore. It doesn't mean para. P now means preterm. So we're going to first of all just start off with just the T-PAL part, and then we're going to add it all together. So term births, again, this is definitely, term is going to be like 38 weeks up. Because we say that preterm is like less than 37 weeks. Now there is that in between. Like, what if the baby was born at 37 weeks and a few days? Is it still preterm, or is it now just kind of round it up and say that's close enough to 38 weeks, and we'll say that the baby's term? That really depends. It really, really depends. And for our examples, we're going to always just try to just keep it simple and say that less than 37 weeks is a preemie. So 30 weeks and greater for term. Preterm would, of course, be less than 37 weeks. And then abortus or abortions, again, could also be miscarriage, but just a loss in general. And this is going to be greater than 20 weeks. And then living. Now, this is now where we can finally add up all of the children, because, again, with the preterm births, what if there were more than one? Then that P is still not going to tell you exactly how many. It's just going to say, this is how many were born. This was a birth. I mean, they were preemies, but it won't tell you how many preemies. And again, the same goes for abortus. It's just not going to tell you exactly how many. But the L will literally just now tally it all up, say, this is how many are living. So like in this example here, you've got a patient who has 2 living children who were preemies. And so what we would do is just say that the T-PAL portion is going to be first 0, even though there's 2 living children who are preemies, we can't give them a score for being term because they were preemies, so they get a 0 for the T. And then for the preemies, of course, even though there were 2, they get counted as 1 because they were born less than 37 weeks. And then for the abortus, so we don't have anything here about losing a child. And then we add them all and say, here is how many living children there are, and that's the 2 there. And then if we were to add in the G with this, which would be the GT-PAL, the gravidity would be, she has 2 living children. So that would be, she's been pregnant once. And if she's currently pregnant, then her G would end up being a 2. So then that would end up being a G2, T0, P1, A0, and L2. Now, before I go on to the rest of this, I wanted to say that there's a video, it's a quick video about 5 minutes that talks about GT-PAL, and from there, it should make a whole lot more sense as far as the way that she's breaking it down. And before we move on, let me just see if you could do a GT-PAL if we just make something up right now. All righty. Another example. Well, you know what? Let's take a break. And then after the break, we can do another quick example and then move on from there. So what is it, like 11:10? So we'll take a 10-minute break and be back.